About 2 o'clock. We're going to go ahead and get started with this session. I want to welcome you all to this session on the evolution of digital health landscape in the era of COVID-19, opportunities and challenges. I hope all of you are enjoying your APHA virtual meeting. I know it's pretty weird for me because I've been going to APHA for the last 10 years, and this is the first time it's ever been virtual. So hope you guys are all having a great experience. I'm very excited to moderate and speak on this interdisciplinary panel that discusses the potential acceleration of digital health due to the COVID-19 pandemic from the perspectives of innovation, business and entrepreneurship, policy and law, and ethics. Today we're joined by Ms. Libby Bainey, Drs. Camille Nebaker and Daniel Hatters, and we will all collectively represent perspectives from these different areas of the digital health industry and from a research perspective. I'll kick us off with a brief overview of digital health modalities and some examples of how it relates to the COVID-19 pandemic. Then we'll shift to a discussion with Dr. Hatters about insights from the business, commercialization, and startup environment and how digital health is really either accelerating or experiencing certain challenges because of COVID and what it may look like post-COVID. Next, Ms. Bainey will be discussing challenges, changing policy and legal issues related to digital health. That can also, one, promote it, but also potentially act as barriers as well. And then finally, Dr. Nebaker will end with a presentation of why addressing actually ethics in the context of digital health, biomedical research, and data generation are some of the most important issues that we have to address moving forward. And she'll be providing some great examples of some of the things that UCSD is doing specifically. The format of the session will be 15-minute presentations from each speaker. We will take 1 or 2 questions after each speaker because people will probably have some immediate questions they want to discuss. If you want to ask questions, please put it in the chat. We're basically going to moderate the chat and ask questions from there. It's been hard for other sessions to have people ask direct questions. So again, put it in the chat and we'll make sure that we're moderating the chat. At the end of the session, I'll also open it up for general questions from the audience. And again, put in your questions into the chat. And hopefully we'll have a great conversation of where digital health is going and the impact of the pandemic on the digital health ecosystem. So I'm going to start us off with a brief introduction to digital health for those of you who may have not had a lot of exposure to what digital health is. And then we'll go straight into the discussion with Daniel Hatters. So give me 1 second while I share my screen. All right, so hopefully that turned out okay. Maybe one of the co-presenters can let me know if the presentation is up okay.
Looks good. You're just only on a partial screen rather than the full screen.
Oh, okay, but it's not on presenter mode, correct?
Yeah, it is.
Oh, okay. Here we go. Does that work better?
Yeah, much better.
Yep.
Thank you.
Okay, great. Thanks for letting me know. So my name is Tim Mackey. I'm an associate professor at the UC San Diego School of Medicine. I'm also the CEO and co-founder of the big data machine learning blockchain startup company S3 Research, which is funded through the NIH and the SBIR program. So that's the financial relationship I'm going to disclose today. As mentioned, we'll have these 4 panelists today, and we'll tackle the issue of digital health from a very interdisciplinary lens. So first, I think the most important thing to approach is what the definition of digital health is. And I like this definition from the World Health Organization because arguably we really need a global perspective on how we kind of do governance around digital health. And one of their definitions is the use and scale up of digital health solutions and how it can revolutionize worldwide policies and objectives of higher standards of health. And one of the things they specifically link it to is something called the Sustainable Development Goals, which cut across a lot of social, sustainable, and human development issues that are really important, including one being universal health coverage, which is in Goal 3. A lot of you are already aware of the different digital health modalities, but we look at things like mHealth, which is the use of mobile phones for delivering health services and information. I know Camille will be talking about that in the context of her presentation, and also Daniel as well. Digital medicine, which is the intersection between mobile, computational, and connectivity. Genomics, IT, wireless sensors, cloud, and machine learning. So bringing all these digital components together, a lot of times in stack-based applications, which really address, multiple modalities of healthcare. Precision medicine, basically tailoring the medical experience to individual patients. The quantified self, which is increasingly becoming something that's very mainstream because people are tracking their health information across multiple devices. And then telemedicine, which of course is something that's really accelerated quite rapidly during COVID. And that will be one of the discussions that we have as well in these talks. So Gartner Hype Cycle has a lot of different digital health kind of parts of it, and each one of them is kind of accelerating differently. So obviously we've gone through the whole revolution of electronic health records, and we're moving forward in healthcare interoperability, but some of the areas that we're still developing are kind of in the machine learning space, particularly the work that I do some in blockchain. It's a fairly still immature area of digital health, but suffice to say, a lot of different digital health modalities are moving along this curve. And I think one of the questions we have for today are how those different modalities are either going to accelerate because of COVID-19, or perhaps have specific barriers that they may experience, which may dampen their adoption. So again, as we talked about before, health IT, this earlier era of health IT with electronic health records and telehealth, been around for decades, arguably, and we have seen some adoption, but even though telehealth has been around for so long, the acceleration it's gone through with COVID is really unique. And then we have more of these, what I would say, modern digital health approaches like big data, mHealth, 5G, of course, and then some frontier technologies like blockchain and even 3D printing that are kind of on the kind of edge of innovation, but may experience either accelerated or decelerated adoption after COVID. So this gives you kind of a timeline of what digital health looks like and maybe where it's going in the future. So the one thing I want to emphasize in this context of COVID-19 is you could somewhat argue that this pandemic is the first in a truly post-digital era. And the fact is we're going to have a lot more likely near pandemics or pandemics moving forward, just because the rate of these outbreaks have really accelerated. So the SARS outbreak in 2002, 2003 really represented the first globalized pandemic, or near pandemic, I'm sorry, it wasn't actually a pandemic, and impacted a lot of countries, and was a time when trade and travel and all of these things really allowed a disease to migrate to one country within a number of weeks. H1N1 could also be argued as a post-digital pandemic. Also a pandemic itself, but a low case fatality ratio, and that's why it doesn't get as much attention as some of these novel outbreaks as well. And then we've had a number of Ebola outbreaks, and then we have things like the avian flu, which we're still concerned about, and could result in future outbreaks as well. To give some perspective on the globalization and digitization of outbreaks, for the Spanish flu, which is what a lot of people are comparing this COVID outbreak to now, basically we had just basically created commercial radio. There's no electronic television, and these were eras where obviously the speed of information and even the interconnection of travel and trade and cultures was very different than it is today. In SARS, again, the first major outbreak in the era of globalization, there was no such thing as Facebook, and social media was just emerging as a technology. And then with H1N1, we saw a rapid expansion of the smartphone market. Apple launched its App Store in 2008. And so again, this is kind of the very beginning of this digital period, specifically for health. And now in 2020, 53% of the world's population is on the internet, and Facebook has 2.5 billion monthly active users, which would make it the largest country in the world if you counted it as a citizenship-based approach. So we're again in a much more digitized environment than we were even in more recent outbreaks. So some of the things that we've been experiencing, all of us have been experiencing in the digital health space when it comes to one, pandemic response, and two, digital health typologies, are things like how do we leverage digital health platforms to change health behavior? And that includes for general public health measures like social distancing, like masking, like good hygiene, things like that. And so you can approach that from different technology typologies like mobile, gamification, AI, big data, robotics, data visualization, and social media as well. Other things that we're arguably working on and prioritizing are infection diagnosis and prevention, digital contact tracing, which has a lot of ethical issues associated with it, and early alert systems. Some of the areas that we really have to address beyond the technology are things like data privacy ethics, which Camille will talk about, getting people to actually adopt the technology, which is hard as well, and then the funding and investment perspective, which is something that Daniel will be talking about. And of course, another red spot that all these red spots are places that we're going to be focusing on in this panel is the changing regulatory environment and whether it's adaptive to this technology or if it's limiting the adoption of that technology. So hopefully we're going to flatten the COVID-19 curve with digital technology, but we'll see how that goes. So in the context of digital health and regulatory science, the FDA has already been making attempts to kind of streamline their regulatory approval process for different digital health software. So I just put this out there about the pre-cert program, which a lot of you may already know what it's about, but really focuses on approving software from who is manufacturing or producing that software. So it trusts that source of information or that source of the software before it worries about an individual product. So how the pre-cert program kind of evolves and FDA's own digital health innovation group evolves is going to be very interesting, because a lot of times the FDA has to essentially make sure they're balancing risk versus benefit of these products. And digital health products often have a different risk versus benefit profile than your traditional therapeutic or diagnostic. Again, I think Libby will actually go into this much further, but I'm just going to put it out there that reimbursement is really changing around COVID as well. So telemedicine reimbursement and how that's changing and how that's enabling practitioners to deliver care where it wasn't available before. Whether that will stay in place or whether that will kind of revert to the median is a very interesting discussion that we'll have in the rest of the panels. I also want to emphasize that some of the most important digital health platforms are being used by governments, by journalists, by the public every day, and they're not exactly government sources of information. For example, the Johns Hopkins coronavirus data visualization is not from the CDC, but arguably more people rely on this dashboard than any other source for global cases and domestic cases. And this was one of the first data dashboards that was set up to communicate to people the information about the macro prevalence of cases all around the world. And again, this is an example of how digital health has liberalized a lot of this data and made it accessible for a lot of different people. I just mentioned that when I was a decade ago, when I worked at the WHO, they had no capacity for digital data dashboards or social media. And now they're a very accelerated organization when it comes to digital health adoption, particularly in the last 5 years, where they've actually installed people that are specific to data science. So it's a revolution, I guess, also in the international organizations about how they prioritize digital health within the context of public health. And of course, if you go to Tableau, their public repository, there are over 30,000 different data visualizations around COVID alone. And these come from state organizations, they come from individuals, and they cover a vast array of issues. This one from Policy Map, that is really a lot of summary statistics, but getting into social determinants of health, things like that are really important as well. So almost everyone has a data dashboard, you can argue, in COVID. And that, again, is proof that the technology is not only available, but data is becoming more liberalized to a certain extent. This is another one just around economic components of the COVID pandemic as well. A lot of other digital health modalities that are very interesting within kind of the computational epidemiology space are surveillance trackers or trackers for symptoms, et cetera. This is one by John Brownstein's group, COVID Near You, which asks people to report their symptoms so that we can have hopefully a better understanding of what the true prevalence is just based on symptom reporting. Interesting here, this was pulled just a little bit ago, but a lot of them are reporting no symptoms versus symptoms. So there are some limitations to these self-tracking systems. And there's also a review article that was just published around what symptom trackers are available and what data they collect. So if you're interested in this space, this is a great article to review. And then quickly ending on this section, I just have one quick section after this, and then I'll be moving on to the next speaker, is things like the Apple-Google partnership on contact tracing, which is unique in the sense that these are two firms, technology firms that are generally rivals and don't generally work with each other. But on public health issues, there's some indication that they are starting to work on things for the benefit of a larger public good. But essentially, there's a lot of issues related to privacy and ethics that haven't really been addressed, even though this technology has been kind of rolled out. So it's kind of the cart before the horse, which I think Camille, again, will talk more in detail about. I just want to highlight a few things that we're doing at UCSD as a university that highlights some of the innovation that goes on all across the world, and specifically at universities. We have medical devices like a ring that tracks your temperature. So a lot of IoT related solutions for digital health and COVID, things like deep learning to detect pneumonia. Some of the stuff that Camille will be talking about Recode and California COVID Notify. And then we also have our own databases and data dashboards that are more specific to local and regional needs. So this is one that's was created by my colleague and is specific to San Diego and looking at case rates and where places are increasing in cases. And this is informing public policy when it comes to school reopenings, decisions by the county. And these are very important data points at the sub-regional level that are very important as well. So just real quickly, some of the work that we're doing as a lab is looking at it from the context of infodemiology. We have a vast amount of information that we can now tap into and try to understand the disease context of COVID from multiple sectors. So we do a lot of work in frauds and cybercrime, which Libby will also talk about as well, the selling of COVID-related fake products online. And then we do a lot of work on the infodemic, which was, if you're curious, there was a session that we held with WHO this morning that you can look at that was all about misinformation around COVID. And that includes misinformation coming from the very highest parts of government as well, like the president. Also looking at things about the early stages of the outbreak in China, understanding how people were reacting to the outbreak then, so they can inform, our actions here and how people react to the early periods of an outbreak and how they understand information. Understanding the geographical correlates and economic correlates of the outbreak itself. For example, do tweets correlate with cases? And this is an example of a map we created where we took the absolute volume of tweets and overlaid it on case numbers. And what we're trying to figure out is if there's places where, for example, in India, there's a lot of reporting of COVID-related topics, but there's not as many cases. And of course, India has experienced some issues with underreporting of COVID. And then again, getting to the regional side, understanding how people are expressing their disease experiences with COVID in a regional context and how that can inform public policy and pandemic prevention efforts. So I'll end there, just mention that we are doing some work on supply chain as well. I think there's a very important discussion around access to medicines that is going to be emerging in the next 6 months about a vaccine and availability. And we really need to address it from a very interdisciplinary standpoint and an equity standpoint and a human rights standpoint. And hopefully digital health technologies will facilitate that discussion and that development. So I am not moderating the session right now, so I'm going to just turn it over to Daniel to get us kicked off with the discussion about how digital health, the ecosystem of digital health is changing and evolving with COVID-19. So I'm going to stop sharing my screen, Daniel, and let you get started. And I'm going to introduce you while you are getting your slides ready, okay?
Okay, great, thank you.
Okay, go ahead and share your screen whenever you're ready.
Okay.
So Dr. Hatters has 20 years of experience in healthcare as a scientist, entrepreneur, advisor, and investor. He's currently the managing director of digital health at NextCube, a frontier technology venture studio and seed investor, where he oversees an early stage investment portfolio of 28 digital healthcare companies that have an enterprise value of over $175 million. He's also an operating partner of Sway Ventures, a US-based venture capital firm where he helps lead digital health investing and portfolio oversight. He's also a faculty member of our digital health program at UCSD Extension. And we were actually hoping for Daniel to be here in San Francisco because he has, an office there. And unfortunately, we're all virtual, but it would have been great to meet a lot of you in a physical format. So Dr. Hatters, take it away.
Cool. Thanks, Tim. And also like to thank the conference organizers for having me. So as Tim had mentioned before, I'm going to speak to digital health from the perspective of an early stage investor. Quickly for background, I am a scientist by training, undergrad, PhD, biomedical engineering, and I've spent my entire career in healthcare as an early employee, a founder, an advisor, an investor in the space. Moving from once was, I started my career in chemistry as a chemist, applied to biology, but now find that everything I do today is in silico, in the cloud, in IoT devices, and I do very little to none in terms of chemistry these days. So this is one hell of a time to be alive, right? Unfortunately, nearly 225,000 people in the United States alone have lost their lives to COVID-19. Our global economy is in tatters, and we're also in the midst of potentially the biggest civil rights movement, certainly in my generation. To put it in perspective, right, COVID-19, the human take, is the worst global healthcare crisis in at least 40 years since the advent of the HIV/AIDS crisis. But more realistically, as Tim was pointing out, the Spanish flu over 100 years ago. The social take, as I was mentioning, is we're living in the midst of the greatest civil rights movement in at least 50 years since the Civil Rights and Voting Rights Act were passed. And the financial take is that we're in the midst of the worst economic crisis in at least 10 years. But more likely, more appropriately, in 90 years since the Great Depression. However, the digital health take is that we're sitting in the middle of the greatest population health opportunity in 160 years since we made the link between clean drinking water and health, but more appropriately, probably over 200 years with the invention of the smallpox vaccine. So COVID has allowed others to see what the digital health startup community already knew. And namely, it's this quote from Walter Cronkite, that America's healthcare system is neither healthy, caring, nor a system, right? We know already, if you live in the digital health startup world, that healthcare is in crisis in this country and globally. 80% of people hold off on preventative care. Women, of course, are more likely to do that than men. And 9 out of 10 parents within this survey were found to be holding off on their own care so that they could provide the appropriate health care for their children. We also see data like this. This is the reality in what many call the greatest economy that's ever been birthed on this earth. US maternal death rates have doubled since the late 1980s. And you can't theorize this away by saying that it's based on race or socioeconomic issues, because although the number of absolute deaths for Black women, for instance, is staggering in this day and time, those numbers have also doubled for white women as well. And you see this from an economics point of view. Since over the last several decades, our spend on US healthcare based on GDP has gone from 5% to over 20%, right? This is unsustainable. And when you look at the slope of this line is not slowing down, right? It's basically a straight line up and to the right. So where are we spending all of our dollars? So most of the publicity of where we're spending our dollars in the $3.5 trillion plus US healthcare economy every single year is on prescription drugs, right? All the prescription drug companies that are gouging patients. And while that may or may not be true, 50% of the spend of that $3.5 trillion a year healthcare spend in our country is actually spent on physicians and hospital services, while only 10% is spent on prescriptions. So anything that we would do in digital healthcare that purports to fix the US healthcare system, by definition, you have to fix the problem of physician cost and hospital cost. And we cannot solve these problems with more people, hospitals, and labs. So what do we do now? Well, with great crises comes great opportunity. And that great opportunity, it's knocking now for digital healthcare. Yesterday's nice to haves in healthcare just became today's need to have in healthcare because of COVID-19. And so we see this literally in the headlines. So if you look at the bylines here in terms of the dates, these headlines are from 2019 and 2018. And what you see here is only a few months ago, people were writing off digital healthcare. Why has digital health been such a disappointment? Is digital health a failure? Why do so many startups keep failing? Well, all of a sudden, fast forward to COVID, and we see now, and you can see in the lower left-hand corner, if you were to survey executives, and specifically healthcare executives, and said, what led the digital transformation of your company? It's not the CEO, it's not the CTO, it's COVID-19. And here on the right in this page, you see more headlines, and you see some of the telemedicine revolution that's been occurring, and how doctors that were hesitant to use telehealth now must use it to stay afloat. You see specialists, so in particular, had been holding back because saying, we can't treat patients over a Zoom call. Well, now they've been forced into this situation, but they've been forced into the situation with more tools than have ever been available before, where true clinical grade care can be administered remotely with the right IoT devices that are always on, that are on your wrist, that are in your pocket, which give you access to your physician essentially 24/7. And this is really staggering. So CB Insights did a survey of healthcare executives recently, and they asked, given the current crisis, which of the following technologies will have the most long-term impact on healthcare? 88% of respondents said it would be digital health and software technologies. Only 12% of respondents admitted that or believed that it would be new therapeutic modalities. And now what's even more interesting is that software is now creating therapeutics. So in truth here, 100% of the future of healthcare is believed to be digital. It's believed to be in the cloud. It's believed to be AI and big data. And so now we definitively know this era is coming. And I'd like to say the digital health revolution has truly begun. And you can summarize it that it's occurred due to COVID-19 in many ways. And this revolution is based on the idea that for the first time since the advent of clean water and vaccines, we now have the opportunity to reduce cost, improve outcomes, and change the social determinants of health, all at the same time because of data. And for those of you that have spent your entire professional lifetime in healthcare, you know that as new technologies, whether they be pharmaceuticals or whatever they might be, come online in healthcare, they always promise that they're going to reduce cost and improve outcomes. But other than clean water and vaccines, that has proven to be false. It's either improved outcomes and increased cost, or it's reduced costs, but outcomes haven't become better. But for the first time, we have a chance to do this on a strategic and efficient level. Data is now the currency of healthcare, and you can see it in this graphic on the right-hand side of this slide. So healthcare used to be the upper left-hand corner. You had payers, you had patients, you had providers, and that was it. But because of data, because of 5G, because of IoT devices, we've now created this box on the lower right-hand corner. And you notice what changes here. Patients, right? They go from being just one stakeholder at this process to being the central stakeholder in this process. And that you can't overvalue how much that means and how that fundamentally changes the way that healthcare is provided and the way that healthcare is created. But how do we really know that digital health is the future of healthcare? Well, the markets are voting for digital healthcare with their wallets. So many of you might be familiar with what I like to call the Teladongo merger. And what we have here is this merger between Teladoc and Livongo in a deal for companies that not that long ago were only worth hundreds of millions of dollars, and now a merger that's worth tens of billions of dollars. And what's really interesting here, once you start to look under the hood, is now you have a healthcare distribution platform in Teladoc being merged with a chronic care disease platform in Livongo. And so now you see distribution and care and that coordination now being lined up where neither one of these companies separately could do what they could do together. And I think you're going to see a lot more of these going forward, because now you're going from platforms that do one thing to platforms that can truly deliver virtual clinical grade care at a distance. We also see these in the VC markets as well. So in the first half of 2020, venture-backed digital healthcare companies raised almost $5.5 billion in venture capital. This is almost equal to all of the venture capital raised by all of the digital health firms in the entirety of 2017. And you can see it far outpaces the first 6 months of any year before this. So rather than the venture community going into a hole and saying, we're not investing here, in fact, the venture community started doubling down. And here you can see what the venture community is investing in, right? The number one funded value proposition in the first half of 2020 was on-demand healthcare services, and then followed closely by the monitoring of disease. So what are those things? That's Teladoc and Livongo, right? And so it's no, those two things are not randomly connected. That's very, very, very much on purpose. And then you see things like at number 7, research and development catalysts. So these are the pharmaceutical companies that have now been gearing up to develop the therapeutics to treat COVID-19. And if any of you have been following the headlines in the VC space, you know, if I redid this for the third quarter, that would probably be way up relative on this chart, because multiple $100 million, $200 million financing rounds have been done with AI drug discovery companies that are on the march to develop therapeutics for COVID-19. What's really important as well is that digital health, really software, data, the cloud, can democratize healthcare, right? It's not just about creating new solutions, but it's creating new solutions that everyone has access to. And the crux of healthcare, especially in this country, is that a very small population receives far too much healthcare, and a very large population receives far too little healthcare, right? And that is the crux of our problem in this country. And that leads to the chronic disease, right? Because so many people are under-medicated, if you will, and too small of a fraction is over-medicated. So much of that underserved population, though, is female, brown, and living in healthcare deserts, both rural and urban. To solve the healthcare issues of these diverse populations, we need diverse founders to be driving these companies. At NextCubed, which is the firm I work with, we've always had a mandate that we've been working towards with a goal of having 50% of the founders of our portfolio companies be female or minority. But we're excited that 100% of our current 2020 digital health portfolio companies are led by female, minority, or immigrant founders. And you might say, okay, that sounds nice, and you're doing something that is of the moment and is socially responsible. And while I won't dismiss we're doing it because it's the right thing to do, it's also the right way to build companies, right? How can you build a digital health company focused on rural female health and have it led by people who are not from those communities. I'm not saying that a white male like myself cannot participate and be a part of that team, but if you don't have teams led by women that are from those communities, you won't have the secret sauce to build those companies. Similarly, if you're building a company serving an underserved, say, inner city, brown, potentially Spanish-speaking population, those people need to be involved in the building of the company. So we do these things because it's the right thing to do, but also it's going to create the best returns for us as investors. And this is not a news flash, but unfortunately, it's been far too long and far too few of these founders have been supported to date. So in summary, the future of healthcare, it's in the cloud, it's on your wrist, it's always on, and it's available to everyone, no matter your race, your socioeconomic status, your native language, and it's AI driven. So with that, I'd be happy to take a few questions.
Thanks, Daniel, very much. We'll give it 1 or 2 minutes for a few more questions, or just a few seconds, but I'll ask the first one that asks for some, there you go. Ask for some insights about how sensor-based technologies, like physical sensor technologies, have been used in the context of the pandemic, or even in the context of perhaps digital health modalities that address home care, contact tracing, other spaces, anything you've seen that's really catching on.
Yeah, so IoT technologies are, they're a must to get to the world that I was describing in my presentation, because as you can imagine, you can have a telehealth platform where a physician or medical professional can be present in the way that we're all present here today. And you can have medicines that you can provide to those patients. But if you can't, if you cannot understand when a person is taking their medication, for instance, and you have no insight, for instance, that patient may not be taking their medication. And if they're not taking their medication, if you know they're not taking it, you can get involved with an AI chatbot and say, hey, Daniel, what's going on? And that chatbot could relay to the pharmaceutical company or to the payer, well, they're not taking it because they've been taking every other dose, because they have food instability at home and they have 3 children and they've had to make decisions between medicine and food, right? And a pharma company can step in and say, we'll fill that gap. Or a payer can step in and say, this is foolish for us not to pay $1,000 a month for this person's medicine and make sure they have no copays, because the expense of not paying that $1,000 a month could be $10,000 a month next quarter. And so those IoT sensors, what they allow is they allow dose level adherence monitoring. And then in between doses, they can allow vitals monitoring. And that vitals monitoring is very, very important, because there's a future, believe it or not, where everyone has more access to their physicians, but physicians actually have to do less. And that's a future where if you're having your health your vital signs tracked at all times, your physician can constantly be monitoring you, but only intervene when your vitals or other diagnostics go off trend. And so there's this dynamic of getting more healthcare while actually taxing the system less. And that's all about having sensors in the home and on your body. And without those things, that future doesn't exist.
Thank you for the answer, Daniel. There's another 2 questions that really are focused on equity, which I think I can bridge together. One is, how do we bridge the gap between areas that have low access to technology, either by reaching out to them or by subsidizing technology access, et cetera? And then related to that, what measures, solutions are in place to address the disparities to that access to that technology, whether it be access to broadband, et cetera? And so if you are using telehealth in a rural area, but there's not a lot of broadband connectivity, how do we address that? And with the rollout of 5G, it's going to be uneven as well. It's going to be highly focused in, highly populated areas. Is that equitable as well?
Yeah, no, it's a great question. And 5G is certainly a game changer, because it enables, I'll just speak. I'm fortunate enough in my home when COVID hit, I upgraded my broadband to gigahertz. And because of that, I've got 3 young children that are in school at home. And we're constantly running 4 video Zoom chats simultaneously without any issues. But that's not a reality for most people or most of this country. There's no doubt about that. And so supporting technologies where when you think about housing vouchers, for instance, we need to be thinking about access and vouchers for access to information technologies and broadband. There's no doubt about that whatsoever. I will say, though, there is a bridge here. So it's not all on the broadband service providers to have to provide for free for all these folks. What's interesting, going back to those IoT devices, because we're now up to 5G, and I've even been involved with these companies myself as an operator, is that those devices operate off of very little energy, oftentimes in the background, and they can communicate with the cloud over 2G and 3G, which still exists and is in the background. And so believe it or not, other than potentially the video component, those devices can operate in rural settings when connected directly to the cellular networks on 2G and 3G. So there actually is no excuse today, if people are properly incentivized, to be able to provide those always on, in your pocket, on your wrist sensors to folks that allow them to constantly be connected with their doctor. And then what's interesting, believe it or not, is that most people actually prefer text-based communication most of the time with their providers, which can be automated through AI in 99% of the cases, and then routed to a human for the less than 1% of the cases where a human intervention or oversight is necessary. So while one is necessary and is certainly inequitable right now among 5G, we can do almost everything we need to do with the tools that we currently have.
Thanks very much, Daniel. I'm going to move on to Libby next in the interest of time. And I just want to mention, Daniel, there's a question specific to what medication adherence sensors you mentioned. So if you can answer in the chat, that would be great. Okay, great. So we're moving on to Miss Libby Bainey. She is the Digital Health Industry Co-Chair at Fagerly Drinker. Sorry, yes. That's the name of the law firm. I hopefully got it right. She's known as a problem solver in public policy and law on issues related to online pharmacy, telehealth, and patient access to safe medicines. She'll talk about the overall policy and legal landscape for digital health, and also provide some case studies on research and partnerships she is leading on. And just want to mention, you know, Libby's very plugged into what's going on the Hill. So she's very aware of all the policy discussions going on around COVID and digital health. So definitely, if you want to ask questions around that, that would be great. So thanks, Libby. Go ahead.
Sure. Thanks, Tim. So I know I'm going to be brief and I talk quickly. So I know Tim well enough that he can tell me to slow down. I want to build off of what Daniel, you talked about, because the vision that you described, and as you're discussing the sensors and the data and the provider use of providers, now we can't build labs or build hospitals to fix the healthcare system. We have to use data in a smarter, better way. All of that from a policy perspective comes down to what are we incentivizing? And if we don't pay for doctors to be receiving this sensory information that they have, they could be flooded with all that information. And if there's not a reimbursement code for them to do that, or if they're not being paid by the health plans or by cash pay, they're not going to do it. And so what the theme of my talk is, what happened? Where were we? Where are we? Where are we going? And I'll spend most of the time talking about where are we and where we're going. But it really comes down to that, and some of the questions in the chat were about what are the incentives to get to 5G? What are the incentives to get access? What are the incentives to get doctors to use the technology? It comes down to payment. And the administration has done a lot in the pandemic era to incentivize use and flexibility around payment models so that people can access digital healthcare technologies and use them in response to the pandemic. So that's my thesis, and I'll provide some evidence to that. And you'll see the slides get into some of this in more detail. I won't read the slides to you, and I'll leave them for your education if you want to refer back to them. Tim did a nice job at the beginning to just say, what are we talking about with digital health generally? You see a lot of different examples here. In telehealth world, I'm going to spend a little bit of time on that because it's really the entry point to digital health in the pandemic response is using telehealth to create or replicate that in-person patient medical evaluation or consultation when we can no longer go in person or for risk mitigation purposes. And there's two types of telemedicine. There's a synchronous and asynchronous. And you'll see that mattering as Dan discussed. We talked about the patient-driven healthcare and that patients at the center. Well, a lot of that comes down to what modality do you want to use? And there's policy and law around synchronous versus asynchronous telemedicine. And there's often rules, regs, and reimbursement get in the way of using these technologies. So I'll talk a little bit about the rules, the regs, and the reimbursement problems for telehealth and more broadly digital health. So what has Congress done? This is the federal response so far. Congress has passed 4 pieces of legislation in response to COVID-19. There's still, and even moment to moment, I'm watching the news to see if there's another stimulus package that's going to be negotiated by the administration and by the Congress. As I last checked about 45 minutes ago, it looks like no, it does not look like we're going to get another stimulus before the election. But deals can be struck in the middle of the night, as many of you know. If you watch Washington or wake up on the West Coast, you realize something might have just happened, especially now in this administration. So today, so far, there have been 4 pieces of legislation that have passed. Some of them have to do with digital health. Some of them are more stimulus-based. The important thing from our perspective and from today's conversation is that flexibility. So I'm going to talk about the themes of the administration's response in the future. Flexibility, fear, fraud, and the future. Flexibility, that's what's happened in the pandemic response. March, April, major changes in policy. Things that telemedicine companies, like you mentioned, Teladongo and Teladoc, things like Hypnosis or other companies have been advocating for years, happened overnight. Quickly, there were flexibilities given by the Centers for Medicare, Medicaid policy, Medicaid services. There have been policy announcements that have added new codes. So you'll see this is all just temporaries. You're going to hear what happened in the reimbursement space. On this slide, I talk about major changes in policy, again, that happened overnight because the administration and Congress added flexibilities to 1834 and the Social Security Act, changed a lot of restriction about where telehealth can be used. This is really telehealth specific and a little bit of remote patient monitoring. But you see that there were lots of restrictions removed. This is the theme of this slide is flexibility. So changes that happened overnight, geographic restrictions waived, originating sites waived. You see new patients being authorized to use these services, different populations, restrictions on audio visual. There's suddenly you could do this in asynchronous ways and synchronous ways. You could use apps and services that you never would authorize before. There were waivers on HIPAA issues. There were waivers, there are new telemedicine billing codes added, which gets back to that reimbursement theme. So all sorts of changes that have been allowed to incentivize or to permit use of telehealth in the response to the pandemic. Again, temporary because it's all under public health emergency authority. So this can go away. I'm not going to read you what the providers have done here, but again, lots of flexibility and what it's federally qualified health centers and rural health clinics can now be distant sites. So major policy shifts, expanding use of different types of service providers, more codes being used, and generally more payments to providers for providing the services via telehealth. So this is the big, the million-dollar question, as it were, is what's going to happen next? So you have all these federal policies that were mostly temporary in the pandemic, and what's Congress going to do about it, or what's the administration going to do about it? You will see, and I'll predict. I think you will have the administration has done quite a lot in either executive order or through administrative action to create a lot of flexibility and to and made a lot of statements about their anticipated use of that technology in the future. Like you can't put the genie back in the bottle, you can't put the toothpaste back in the tube. Those analogies are things you've heard from the administration and from Congress. So that's the flexibility piece that I mentioned. But you also have the fear and the fraud problems. And so there's a fear in Congress that there's going to be overutilization of these services, that they're not as reflective of the demographics that need them. So it gets back to equities. in access to healthcare issues generally. So there's some fear around making these policies permanent if you don't have equitable access, if some populations can't use the services as well as others. And there's a fraud component to that as well. Will there be overutilization? Will it not be appropriate care measures? Will there be patient harm? And so there's a real need for data when policymakers are using, sometimes data is a crutch, sometimes data is really important. And in policy right now, there's this push-pull of, do we really need to collect more data to prove the value proposition of these services when we're using them in real time and it's helping and stepping in and filling gaps? Or will Congress require more data collection and do more studies about the effectiveness or about fraud, waste, fraud, and abuse before they make some of these policies permanent? So those are some just broad themes that overlay on the details that are presented here on the slide. So I talked a little bit about what Congress is contemplating. There's legislation that's been introduced by telehealth champions. I'm happy to talk about it offline if you want to know the details of what these bills would do. And then there's this big question on this data utilization. Do we need to, will Congress act before they collect and review all what has happened, or can they take what has been permanent or temporary in the public health, under a public health emergency, and make it permanent just based on real world evidence and real time patient experience? And that's the policy push-pull that we're wrestling with today. So some policies could be made permanent by agencies. The point here is it doesn't require Congress only. That's only one branch of our government. The administration could do some things and have already done some things to make to suggest policies will be made permanent. They haven't done it yet, but some of these could be made permanent just by executive action. And here's just a short list of those as well. CMS, Center for Medicare and Medicaid Services, is doing a number of different things. If you follow physician fee schedule and look to reimbursement models, again, there's a lot of flexibility and new incentives for physicians to be, and new codes for physicians to be using telehealth and digital health services, remote patient monitoring, and telehealth going into the 2021 fiscal 2021 budget year. So that's sort of where we have been in policy. And I forecasted the future on flexibility, fear, fraud, and the future of digital health. I think this nicely builds on what you discussed, Dan, which is when you have patient-driven healthcare, in many cases, when you have demand rising, and if there's flexibility baked into the future of healthcare, so if those policies are made permanent, if there's reimbursement that creates incentives for doctors and hospitals to use it, if there's actual payment models that support patients using it without having to pay out of pocket, so they're used by their existing plans and used by the government payers, rather than having to just constantly pay out of pocket for something that otherwise could be provided as part of a care package that you might already be paying for or covered by the government. If those policies that I just discussed continue and made permanent and even expand, you will see a dramatic shift into the future that Dan offered us of using those telehealth and digital health services. If they don't, that future is, in my policy legal world, much more limited, because you have less incentive for the innovation, you have less incentive for patients to use it. It's much harder to get people to actually, check those records or make it a part of healthcare in the way, which gets back to the 2019 vision of digital health is dead, it's dying, there's no incentive. I really liked your discussion, Dan, about how yesterday was a nice to have and today is must have or need to have. And I think the data, I'm going to just quickly go through some of this data, shows that consumers want this to continue. And so one of the organizations that I work with, the Alliance for Safe Online Pharmacies, did a recent study this summer trying to understand the shift between digital health use in 2017 to today. And the Alliance for Safe Online Pharmacies' point on this is people historically have sought medicine online, medicine specifically, not just general healthcare, but specifically prescription drugs online for a number of reasons: cost, convenience, and access to care. No one's surprised by that. Those are the drivers. So in 2017, the nonprofit Alliance for Safe Online Pharmacies did a study, a US survey, trying to understand what are driving cost, convenience, and access to care. What do patients know about prescription drugs online? And will there be fraud in the mix? Will they be defrauded by buying from an illegal source, by getting bad drugs, by getting something that's not FDA approved, by getting something that's counterfeit or substandard? Going back to that fraud piece that Congress and policymakers are really worried about. I won't, again, read this to you, but I think some major takeaways from this slide is 36% of Americans are currently using the internet to purchase prescription drugs. That's a change from 2017, which is just up by 3%. But you'll see the change in drivers as well here. Cost and convenience continue to be major drivers. And more than a third of those people that are now buying medicine online are doing so because of the pandemic. So nobody's surprised by that, but the data that you'll see later in this presentation shows that's going to only increase. And so the future can be bright if we can distinguish between fraudulent actors on the internet and those that are legitimate and potentially, hopefully, reimbursed as well. So again, one of the interesting takeaways is what's the provider-patient relationship look like in the future? And especially when things are mediated by sometimes asynchronous interaction, where the doctor may not even have this kind of live experience with the patient. How much does the patient think they need to have a relationship with their doctor? How many doctors are having discussions with their patients about where they buy their medicine? And so the data here just shows, pharmacists, 71% of pharmacists have not discussed buying medicine on the internet with their patients. That's shocking because they're frontline providers. You can access them at any point, and yet pharmacists aren't having this discussion about where people are getting their medicine. Are they buying online? And I thought that the statistic about 29% of people are somewhat likely to order prescription drugs without any type of doctor-patient interaction. Just pure, I will go to the internet and buy and order medicine. And that is a major shift in our in consumer-driven healthcare, as instead of being brokered by the doctor-patient relationship. So there's risk, and I think we'll hear a little bit about some of the ethics around all of this as well. I raise this because there's this other angle to COVID and digital health response, which is there's thousands, 35 to 40,000 active online drug sellers operating on the internet at any one time, meaning patients can try to buy COVID cures, COVID treatments, COVID test kits on the internet from any number of search engine driven websites, social media companies, and online marketplaces. It's very easy to find healthcare products on the internet. Most people do not know about the risks. And so we were trying to understand through this survey, the Alliance for Safe Online Pharmacies wanted to know, how do Americans distinguish between safe sources of online healthcare using telehealth, legitimate telehealth interaction versus those that might be being fraudulent. And you can see some indicia of legitimacy, or they look for URL accuracy. Some look for the .pharmacy, which is a digital health certification program by the National Association of Boards of Pharmacy. But there's really limited awareness in how Americans can distinguish. So for a company that might be in your portfolio, Daniel, I'd say if you're going to market, you need to make sure that there's a clear delineation between legitimate healthcare and digital health online and bad actors and illegal online drug sellers. And if you don't, when that market gets blurry, there's an erosion of the value proposition for the portfolio companies. And more importantly, for public health, there's a major risk to consumers and to patients because they are not talking to their doctors or pharmacists about digital health on the internet. They're willing to buy online without having the doctor-patient relationship, and they don't distinguish between legitimate and illegitimate sites. That combination of factors is a real opportunity for criminal activity and for consumer fraud. Again, just put a little bit of final color on this, and I'll turn it back over to Tim, showing 72% percentage of respondents plan to continue using prescription drug sales online post-pandemic. So that trend line of digital health utilization continues to go up, online pharmacy in particular. And I think there's a real interest in online pharmacy layered with telehealth, layered with potentially some additional sensors or some type of Internet of Things type of monitoring to know, are people taking the medicine when they receive it? There's a lot of really creative things that could happen when you look at that trend line, if the rules are appropriately aligned and if there's reimbursement and if you can regulate out bad actors that could hurt patients. Take you through that as well. So I will stop there. I could go on about this topic, but I know there's additional speakers, so I'm happy to take questions. Or Tim, if you'd like, you could keep my questions for the end so that we have enough time for our next speaker.
Yeah, I just want to, thanks very much, Libby. That was a great presentation. I want to ask one quick question that's related to some of the comments that are coming in. One is the elephant in the room, which is the elections coming up in a week and a half. real quickly, are these digital health, proposed policies, legislation, et cetera, are they bipartisan issues, or are they focused on,
Yeah.
specific areas of the economy? And related to that, if you can answer this like as a 2-point question so we can get to the next speaker, are any of these policies focused on certain populations that are at higher risk, or are they just blanket policies?
Yeah, that's a great question. So generally the administration's response to and telehealth generally is bipartisan. So the bills that I mentioned that have been introduced, the Connect for Care Act, example, is a bipartisan bill. It is widely known, both in the Senate and the House, as a bipartisan issue. But there are slivers or population-specific initiatives. So the Connect for Care Act has lots of different provisions, and in that there are certain types of there are certain provisions that would address a different substantive issues. And so, to answer the second part of the question, are there some, whether in Congress or administration, that want to solve only a slice of it for a certain type of population, for a therapeutic area, for a disease state, for a demographic? Yes. And there's a lot of real interest in the social determinants of health and how telehealth and digital health could help address social determinant issues. And so I see those two things merging in the next administration and in the next Congress. But right now, the bills are very much bipartisan and are pretty broad in terms of just creating access.
And then we have one follow-up question in relation to, obviously with more people being online, you get exposed to good and bad information, but it's oftentimes very hard for consumers to distinguish because a lot of the information isn't complete yet when it comes to what available treatment there is, what testing availability there is, et cetera. So what clear policies could help people differentiate between legitimate healthcare sources versus bad ones? That's a question that just came in now.
Yeah, that's a great question. And I'll give a really short answer to something I'd love to discuss offline. Please contact me to discuss more. The short answer is we need the digital health platforms to be part of that solution. So you could put out the best healthcare information about how to access a COVID test site, but if the first thing that people find in social media results is a fraudulent social media post about where the test site is, just like in dropping ballots, and just like in any misinformation or disinformation, it's what people see at the top of the results. And so part of what one of the clients that I work with, the Alliance for Safe Online Pharmacies, is doing is trying to educate policymakers and Congress about the importance of putting public health first in policy when it comes to platform regulation and online accountability. And that's from search and social and online marketplaces and domain name registries and registrars. If you think about the digital supply chain of information for public health information and for public health access, so prescription drugs as an example, we need to regulate that digital health supply chain in a similar way as we did the brick and mortar drug distribution supply chain, from wholesalers to pharmacies to manufacturers. And we have an online supply chain of healthcare information and healthcare access and medicine that needs to have some accountability as well. And there's lots of policies that could do that, and I could discuss that again some other time.
Great. Well, thank you very much, Libby. And we're going to go ahead and move to our next speaker, who is Camille Nebeker. She is a professor at UCSD, along with myself at UCSD. And she directs the UC San Diego Research Center for Optimal Digital Ethics, also called RECODE. And she's also an associate professor, as I mentioned, of behavioral medicine in the new Herbert Wertheim School of Public Health and Longevity that we just started at UCSD. She's really a leading ethicist in the space of digital health technologies, focuses on research literacy in community settings, and examining ethical and social implications of technology used in health research. And I know she's pushed back on some of my research, which I appreciate, because we need people like her understanding, yes, digital health is important, but we really have to think about the ethical considerations of a lot of this data generation before sometimes we launch these initiatives. So Camille, go ahead.
Thank you so much, Tim, and thanks to the organizers. This has just been a fantastic panel. I'm thrilled to be a part of it. I don't have any financial disclosures to tell you about. And one of the things that I like to start out with when I talk about the ethical implications of digital health is really thinking about what does that mean. So Libby just gave a really beautiful overview of the legal and regulatory considerations. Where I want to focus is more on ethical principles and how those get expressed in practice. So ethical principles that really guide the work that I do, which is really about digital health research rather than digital health clinical practice. So I'm really in the academic research area where we're using different kinds of digital tools and strategies to learn how we might influence behavior change. And so because I'm anchored in an academic setting, we have federal regulations that guide research with human subjects. Part of those regulations are involve our agreement with the government when we accept funding that we will apply ethical principles to our practices. And that really focuses on informed consent, which aligns with respect for persons, the risk benefit assessment, which aligns with the principle of beneficence, and making sure that when we conduct research that we engage people who are most likely to benefit from the knowledge gained. And so that maps to the principle of justice. Now, new things that are happening are because of the way technologies are able to capture information, we're now having to struggle with what happens when people who are not research subjects are captured in the data collection because of their proximity to somebody who's wearing a digital sensor who captures their voice or captures their image. So there's some really new twists to the kinds of ethical challenges that we're seeing. I'm going to skip over the regulatory and go into the social lane, which is looking at what kind of downstream impacts that these socio-technical systems might have. What are the known risks, but more importantly, what can happen downstream that we may not be aware of? And then we think about what privacy expectations people have, how that differs across generations, where our digital natives may have a really different idea of what privacy means to them and their willingness to trade it versus older adults. And then the newer area that is really tied nicely to digital health is how do we give information back to people? In biomedical research, it's not traditional to share information that we learn from research studies back with our participants. But because we can capture information in real time, and oftentimes sharing that information back with participants is part of the research design, the intervention, we're really thinking a lot about how do we return information back to people so that there's a value add. So that's the grounding. Digital health research snapshot. These are the different sources of data that we can now have in real time. We are able to not only look at genomic data, which has been, something that has been possible for the last 20, 30 years, but we can now have remote sensors that pick up on environmental signals. We can look at the electronic health record, make some do predictive analytics to see if we can start doing diagnosis more efficiently using AI. We can look at Facebook and Twitter, some of the work that Tim's doing to understand what's happening in populations. Those data were never intended for health purposes, yet they're being leveraged and increasingly leveraged to use in health decision-making. So mobile methods, we think about the use of a smartphone, how we can deploy ecological momentary assessment surveys in real time, capture data in real time, not have to rely on somebody reflecting 2 weeks ago, what did you eat? How much did you exercise? We don't have to have people come into a lab setting. In their natural environment, we can now capture information about what they're doing in that moment. This is a wearable camera that actually got me involved in digital health research ethics, where our colleagues wanted to use wearable cameras that face outward to capture what the context was of what that individual research participant was doing in their everyday life. So again, rather than wait for them to self-report, we could look at different kinds of wearable sensors to see whether or not physical activity correlated with where they were in the environment. We didn't have to ask them a question. We were just able to passively capture all of these data. But this camera really created some new challenges, especially for the institutional review boards that review these studies, because if I agree to participate in a study that uses this camera and I'm wearing it, then anybody that's in my vicinity in range of my first person perspective is going to get captured in that research record. These are wearable sensors that are skin applied. This was made by Todd Coleman. bioengineer who works nearby us. And so you can see in the sensor, which is about 1 inch by 1.5 inches, it's applied to the skin. It has all of these different sensors, temperature, ECG. It can transmit physiological data in real time through a smartphone to a provider or to a researcher. So we have to really think about not only how convenient this is, we also have to think about how accurate is it and what can happen during that transmission. So during the last 8 years that I've been working in the digital health research ecosystem, all kinds of new tools have come out. And so, we're using, as I mentioned, Facebook and Twitter. Instagram is being used for research purposes, mostly to reach people for studies involving men who have sex with men, mental health disorders, really stigmatizing situations where normally people would not volunteer for studies like that, but are much more willing to participate if they can do it through a social network platform. Epidemiologists are using Runkeeper. There's all kinds of new big data sources that are being leveraged for health research. So these new methods result in new types of data being collected, very granular, so much in terms of volume that what we learned was IRBs didn't really know how to manage this, nor did they know what kinds of questions to ask, which has really prompted us to get researchers more involved in governance so that they can have a much more active role in shaping what the ethical best practices are, and really not rely on IRBs to be the go-to for answering questions that are basically, how do we protect our research subjects? And as we were doing these studies, and this was before these commercial products came out, Fitbit came out about 8 months after I started the research. And what we've learned is through the terms and conditions of service, we found that there's a direct violation between terms and conditions and federal regulations. And so that's been problematic in terms of allowing researchers to use some of these products. One of the things we're doing now is trying to get vendors, health technology companies, to be what we call research friendly, so that they will be in alignment with federal regulations so that they can be a go-to tool for researchers. As Tim mentioned in his opening slides, we have so many different kinds of researchers nowadays because of access to technology. This is not quite a completed figure, but my goal here was to show the variation in regulated versus ethical acculturation versus trained and untrained. So on the far left, we have people that are doing research, do-it-yourself research, participant-led research, citizen science, people that want to start doing N-of-1 research. Some people want to do self-study, but they don't really know how to do it, yet they want to do it safely. And so our team has been involved with helping to educate people that are newly involved in research, but maybe don't have ethical acculturation nor formal research training. And as you move to the right, it moves from very little research training to very rigorous research training, very regulated research, and a big emphasis on ethics acculturation. So the pre-pandemic questions that we had was, we can't promise data anonymity anymore. So that's not realistic. We can now know everything at a very granular level. Not everyone in the emerging digital health research system are regulated. And now we can monitor people in real time, 24/7. And that's just a reality that we're facing now. So it's an entirely different kind of research. That's led us to doing a ton of research. We've been looking at how IRBs make decisions. We've been looking to see how participants think about risk. We've looked at the digital divide, especially here in San Diego County, where we have a very large Latino community, a decent, probably the second largest Native Hawaiian Pacific Islander community in the United States, a large refugee community. We are an area where people are retiring, so a large older adult community. So we've been doing a lot of research to better understand what's happening. And that has helped us think about what do we want to do in order to help digital health move quickly in response to this pandemic, and do it in a way that's going to be supportive rather than, an eventual train wreck. So I think this is a really interesting quote that just came out last month, where I've been worried about all these companies that have suddenly pivoted to COVID overnight. And so I feel like every business plan, they crossed out AI and wrote in COVID-19. And I think this is a really important statement that, you know, taking advantage of a situation is important. You want to make the best out of a crisis, but we really have to be mindful about what goes into, you know, changing a business model. This is a new initiative that started right about the time that COVID was happening. It's called Just One Giant Lab. It's based in France, and it is a global platform for people who are citizen scientists to do research to help solve the COVID initiative or COVID problems. So you can go in here and look at different kinds of studies that are being done or proposed. They're live. They may or may not have an IRB approval. They may not need one because they're not regulated. So, but it's happening. People are doing research to try to figure out how to solve their problems. This is a piece of that where George Church and his colleagues have come up with a way of creating a do-it-yourself coronavirus vaccine. They send the parts of it to people that want to try it, and it's not FDA regulated. People will put together the parts in their own home and use it themselves. And then the idea is that they would keep track of how they're doing. I don't really understand how the research is being tracked, but this is part of the do-it-yourself biohacker environment. And then in science, shortly after COVID was out and moving, we started seeing an awful lot of research on how to do digital contact tracing, which I was absolutely just obsessed with. And I have a huge database of all the different articles that have come out since that time. In this case, it was just a really beautiful article about why digital contact tracing could be incredibly important, how you would do it. And at the end of their article, they identified 8 different ethical practices that would need to be implemented in order for this to work. And you know, it's clear that we have this tension between privacy and public health. This came out in February, right before I was going to DC to give a talk at the National Academies, where, you know, we can take cell phone tracking, we can use all of these different signals to help mitigate the spread of COVID, and privacy is the price. So how do we do this? And then on the right side, you can see a picture of the Aura Ring, which is now actively involved in tracking your symptoms, your body temperature, your sleep, respiration, to see if they can use a wearable technology to identify COVID before a test even occurs. So at UC San Diego, I wanted to give you some examples of what's happening. We have a program called Return to Learn. Within that program, we're trying to figure out what are the safest ways to bring our students and faculty and employees back to work. So we have risk mitigation, we have viral detection and intervention, and the environmental monitoring and the contact tracing and exposure notification are areas that I'm particularly interested in because it's surveillance. How do we do that in a way that is respectful, that is acceptable, that is likely to promote acceptance rather than rejection? And so a new kind of college exam, UCSD is testing sewage for COVID. And so we have one of our very well-known and respected microbiologists who does microbiome work, Rob Knight. And so he and colleagues have created some testing that can be done to look at sewage in the UCSD campus area and have been able to identify positive exposure for COVID from that first detection early in September. They asked people who had used the bathroom within a 3-hour period of time on a specific date to get tested. From that, they've identified 2 employees that were asymptomatic. So that would be something, this is obviously a clear way that you can mitigate the spread. The other one that we're pilot testing for the state of California is the California COVID Notify system. This is the Apple-Google partnership. They have the platform. What we're doing is trying to see whether or not our students, our community basically, will adopt it. So there's a lot of information going out to the campus about it. One thing that is really important is that in order for things to be acceptable and adopted, which is the only way they can be successful, is to think about what the ethical underpinnings are. And so when we think about contact tracing, digital technologies for surveillance, something that the World Health Organization said is you have to engage the citizens and have public engagement in order for this to work. Well, not much of that's happening in our UC San Diego community. So our thinking has always been, and we adopted this from Omidyar, is to move purposely and fix things. And in keeping with that, we are working with our community to think through what are the tools and strategies that we can take from our ethics work and apply it to making some of these strategies stick for our campus. So in order to help this return to learn succeed, and the exposure notification in particular, we're taking from many different, we're basically using human-centered design in this, but we have always worked with people in order to design and deploy anything to do with our own ethics research. And so we're in the process right now of engaging students, faculty, staff, and now community members in conversations. In fact, we've done one design sprint, which was last week, one design sprint that's coming up this week. And the whole goal is to not change the Google Apple platform. We can't do that. But what we can do is change how we communicate and message about it so that people are more likely to adopt it. But the messaging is only going to work if we can mitigate trust issues, privacy concerns, and the things that people really care about. So in order for any of these technologies to work, we really have to unpack things that keep people away from adopting them. So as Tim mentioned, I am director and co-founder of the Recode Health Center at UCSD. And our whole focus is on helping this ecosystem think about what are the ethical, legal, and social implications. We have education and we have some tools that we're using to support decision making. I'm going to go through these really quickly because this is a framework that we've developed that really is trying to help all people in the ecosystem think about what they need to think about. And so this is the framework. It's grounded in ethical principles. The 4 domains that were generated by the research community was privacy, risks and benefits, data management, and access and usability. So this is published. You can see the paper and you can access this checklist on our website. But this is basically what it is we've unpacked the ethical principles, which you see on the right, and identified what kind of questions you would want to ask yourself, whether you're a tech developer or a health system implementer or a municipality that's trying to make a decision about digital contact tracing. These are all the questions that we help people think through. And so for each domain, we have questions and risks and benefits, privacy, data management. And these again this is one of the only tools that is in existence to help people think through what they need to think about and act upon. So I will stop there so that we have some time for questions for the group. But if you want to contact me, here's my information as well as our center information. And I will stop sharing at this point. So thank you, Tim.
Thanks very much, Camille. You covered a lot of ground and brought up some very interesting questions. We have about 6 minutes, so I'm going to limit the Q&A here to a discussion about what Camille just went over. One of the questions that came up was a question for clarification, which was, what was ethical acculturation? Someone asked that. I think you mentioned that in your talk.
Yeah, so as an academic, especially as a researcher, we have to go through different kinds of trainings. People who become clinical psychologists get clinical training in ethics. If you are a researcher, you go through research ethics training. And if you're working in the pharmaceutical companies, you probably have a different kind. There's good clinical practice, different ways of learning how you go about doing your work respectfully, safely. With the digital health in the ecosystem, if you have citizen scientists, do-it-yourselfers, they don't have that kind of training. So when I talk about acculturation, it's the extent to which you have been exposed to ethics related training specific to your profession.
Great. And then something related to a lot of the questions here is you talked about, so actually Daniel talked about patient-centered digital health. You're talking about ethically centered digital health intervention and design. Not necessarily those things sound complementary to themselves, but they're not always talked in that way. So could you expand on that?
Yeah, so like with wastewater surveillance, in order for that to be acceptable or for the exposure notification, we want to bring the community together to talk about things that are barriers to adoption as well as facilitators to adoption. And by engaging the community to look at what affects access, what influences usability, what is their worry around privacy, trust, all of these words that I'm using map to ethical principles. So when I talk about ethical principles, the practices are how do we demonstrate respect? And all of those areas are what we try to talk about. We do that not only when we design a program that's ethical and respectful and responsible, but also when we design technologies.
Yeah, great answer. Because I think there is a lot of compatibility there, but there's not as much discussion about that compatibility.
I think people worry about the word ethics. And so that's why I try to break down what it actually is in practice, because people go off into philosophy or somebody else does that for us, not us. And we really, as a community, have to own this, because if we don't collectively take action and be a community that knows that we're all responsible for it, it will fail.
Great answer.
I'm trying to make it accessible, right?
Absolutely. And so I'm going to leave this conversation, because we only got about 3 minutes, for a last question for everybody. If you were to say to a policymaker, we'll just make this policy focused, what should be the focus for digital health, in the next year or so, what would it be? So maybe we can start there. Or you can answer the question any way you want, or you can just have some closing statements. I just wanted to let everyone have a chance to end with some thoughts. So maybe Libby, you want to go first?
You're muted.
Sorry, everybody has to do it once. I would say a simple answer, which is make what Congress has passed and what the administration's done in the pandemic public health emergency permanent. If we made that permanent, I would argue for expansion of that, but baby steps first. Keep the gains of what we have for reimbursement and for access and for provider flexibility, and build from there.
And really quickly, Daniel, related to that, do you think these case studies or use cases for digital health and COVID are here to stay, or are they just parlor tricks, and they're going to be things that everyone wants a use case for COVID, and same with policy? Are these really here to stay?
Yeah, it's a great question, because I think that some people will, when COVID is long gone, some people will go back to their old routines. But I think what happened here is that there's so many entrenched stakeholders and entrenched behavior in healthcare that we were never going to change without it. And I do think for a large majority of people, they've now realized that they don't have to go and sit in an office and fill out paper forms and wait in a triple booked environment. And physicians now realize that they can make the same or more money with less hassle and provide better care at the same time. So I think, will it stay like this? Absolutely not. But I do think that a new reality is upon us. I don't think we're going back to the old way. I think a new norm has been established as we move forward.
Yeah, and sorry to preempt all the questions, but we'll end with Camille again on this question of, digital health looks very promising. Is ethics really going to be at the center of design, or are we still going to struggle with making it part of the design and business considerations?
Well, I think, when it comes to policy and access, we really need to think through whether or not these technologies and tools and relaxed regulations are resulting in increased access for those who are typically underserved and hard to reach. So I work with older adults. They don't have access. They don't have connectivity. The few people that I've engaged in research in the last 6 months are only those that can get on Zoom. And that was 25 out of 300 people in a residential retirement community. So these people have means, but they don't have access. If they have access, they don't know how to connect. So are we increasing the distance, or are we tracking that and making sure we mitigate as we move telehealth and digital medicine forward? So I think that's a critical pay attention to this so we don't exacerbate harm.
Great. Well, we're ending right on time. I want to again thank all the panelists today for a wonderful discussion about digital health, where we're going, different perspectives, definitely. And we will definitely see how digital health accelerates or what challenges it is affected by moving forward. And I just want to close for all of you attending APHA. I hope you have a great rest of the conference and stay safe. So thank you very much and have a great day. Thank you.
Thank you.
Thank you.